Hello, this is Dr. Mary Grady, and you are in Nursing 122, and I'm trying to open this thing up called seizures. What is a seizure? It's a period of abnormal electrical discharges in the brain, and they're believed to be a result of these abnormal, excessive electrical discharges that are happening due to chemical changes in neurons. And these neurons are creating this electrical negativity that causes this particular discharge. Over 3 million Americans have suffered from seizures, and epilepsy, just to let you know if that word were to come up, is just a chronic disorder that's characterized by unprovoked seizures. So if you have to get that definition of epilepsy, you would have to have so many different seizures over a period of time. But seizures in general can be things that just happen one time. When this is happening, these electrical discharges in the brain, they can occur for many different reasons. They can be triggered by environmental causes, like maybe you're exposed to some chemical that's in the air that triggers this. Maybe it's physical stimuli. Maybe it's acute insults. Maybe it's trauma. Maybe it's because you had a stroke. Maybe it's because you have intracranial pressure because you have meningitis and the meninges are like inflamed. So there's many different reasons that this could happen. When you have a seizure, there's two kinds of seizures that they usually talk about. One is focal. A focal seizure is also known as a partial seizure. That's what they used to call them back in the day, as they were partial. Now they're trying to call them focal. So depending on your resources that you're looking at. And a focal seizure just means a seizure that's occurring on one hemisphere, just one side of the brain, or in a specific area of the cerebral cortex. A generalized seizure is a seizure that's happening on both sides of the brain. So it's happening all over the place. So what causes these seizures? This abnormal discharge of electrical energy in the brain, where does that come from? Well, sometimes you don't know. You have no clue. They'll test you to try to find a cause, and sometimes everything just comes up negative, and it is what it is. And so then they call that idiopathic. Some are caused by some underlying pathology, like maybe the meningitis that I mentioned, maybe cerebral palsy, periods of hypoxia to the brain. Maybe it's febrile seizures. And febrile seizures are generalized seizures, and they normally occur in children. Primarily like 3 months to 5 years of age is when you most see them. And it happens because children, their body and their body systems are not mature yet. So when they get a fever and the fever advances very rapidly, the body doesn't have time to adjust to this rapid movement of the temperature going up, and it triggers a seizure response. Usually if a temperature is around 102 Fahrenheit or 39 Celsius is when you would see this. And a lot of times it happens in people who are children that have family histories of the disease or have family histories of febrile seizure. They're more likely to have one. But it can be just in any child. My mother tells me that when I was a child, I was 2 years old, I had a febrile seizure, and they had to take me to the emergency room and all of this. But it was because my temperature came up so rapidly. So that's something to keep in mind with children. So what are risk factors that make us prone to having seizures? Well, we already talked about like children, the febrile, the immature body system. Just to let you know too, infants are susceptible to developing epilepsy during the first year of life. And especially with just if they're prone to that, or if that was a disease they were going to have, you might see that show up. Other risk factors are babies that are small for their age, gestational age, brain tumors, strokes. That's causing increased intracranial pressure on the brain. And as we talked about before, you've only got so much room up in that head to house your beautiful brain. And anything else in there, like a tumor pressing on it, or like a blood vessel that's that's busted and is hemorrhaging, or like with a stroke, hypoxia triggering that. A lot of times you see people with autistic disorders that might be prone to seizure disorders as well, because there's already an underlying neurological condition, which is the next thing in line. Infections of the brain, like meningitis, um, could be a cause, because that's causing increased intracranial pressure, destroying parts of the brain and different neurons and tissues. Cerebral palsy, because of the lack of oxygen to the brain. They were hypoxic at moments during their birth. And then drug abuse. Drug abuse is becoming a huge one, especially in this area with the opioid use. Seizures and heart attacks are becoming very much so because of the use of drugs. So, how can we prevent this? Well, sometimes you cannot, because it's that idiopathic thing. We can't do anything about idiopathic. And everyone has a seizure threshold, and if it exceeded, the seizure may occur, especially if you're prone to that. But they have noticed that in people that are prone to seizures, certain things can trigger them, like fatigue, hypoglycemia, fever, alcohol consumption, hyperventilation, or menstruation, are all things that can lead to the person having the seizure that is triggered. So when a person has a seizure disorder, one of the best things we can do as nurses is kind of encourage them to take good care of themselves. And all those wonderful things that we keep talking about that you need to do, like eat right, exercise, get plenty of sleep, that can be very helpful to someone that's prone to a seizure disorder from avoiding anything that's triggering. So what happens when you have a seizure? Well, all seizures, once the minute a seizure starts, you need to kind of get an idea when it started and when it stops, so that you can tell people exactly how long it occurred. Maybe it was 20 seconds, maybe it was a minute, but that's information that's very helpful in the diagnosis and trying to figure out what kind of seizure it is. Also, during a seizure, one of the most important things you can do is make sure someone's airway remains open. You're not going to get in there and start messing around with the person. You're just going to keep them safe. Let the seizure just happen. Don't do anything unless they look like they're going to hit themselves or fall and get hurt, and then you might need to touch the person. One time I had someone having a seizure. I just watched it and looked at my watch to see how long it was going to last. But then during the seizure, the person became blue because their airway was occluded. So I just reached down and repositioned the head a little bit, the way you learned in CPR to open an airway, and that was all that was needed. I didn't restrain the person. I didn't try to stop things from happening. It just occurred. Now, all seizures have 3 phases that people look at. There's a tonic phase, a clonic phase, and the postictal phase. During the tonic phase, that's the beginning. That's when it's first happening. The person becomes unconscious. They're not really knowing what's happening at this point in time. And there's this continuous muscular contraction that's occurring. Now, also what happens is the basal metabolic rates start to go up of your body, because your body's like, oh gosh, it's like I'm running a marathon here. So I need more oxygen and I need more glucose. If the seizure continues to go on, you may see the person get pale or cyanotic because of this hypoxia, lack of oxygen to the brain, because the brain cannot take in all this oxygen during the middle of the seizure. And they might become hypoglycemic because they've had to use up all their glucose stores or use up a lot of glucose during this attack. Having a seizure is like running a marathon. Then you go through a clonic phase, and this clonic phase is kind of the middle period here. You're alternating muscle contractions and relaxation. So they go from being really tense to now it's tense, relax, tense, relax. And then you get the postictal stage. And that is the stage that follows the seizure activity. The person is very tired. They're very sleepy. You can still arouse them, but they just need to rest. It's like they have exhausted themselves. They have ran a marathon, and now their brain needs to rest. Another thing I would like to point out to you is in your textbook, there is a wonderful chart in your required reading, and it's called Clinical Manifestations and Therapies for Seizure Disorders. And it gives you a lot of information about the different types of seizures. So as I'm timing this seizure to see how long it lasts, and as I'm watching the person to make sure that they stay safe, and they do not hurt themselves, I'm going to try to look at characteristics of the seizure. Like I said before, you have generalized and you have partial, and there's different definitions that fall under each of those that you should kind of look at. And then you have the tonic-clonic, which is more generalized. The whole body is going on, all the stuff at once, and that's the most common in children. When you get into like the partial, there's a lot of different movements, things of that nature that you might see, especially like if you have a simple partial. That's one of the ones that could happen. And in a simple partial, there's no alteration in consciousness. The person still is with you. The only difference here, because of this disruption in the autonomic nervous system, they might have tachycardia, flushing, hypotension, or hypertension, and they may have a sense of deja vu, or they might start to get really irritated, or they might start to have little muscle contractions on just one part of the body. You have complex partial as well. And usually these complex partial is preceded by this thing called an aura. People kind of get a sense that the seizure is about to happen. Something triggers that, and it's an early warning sign. And then they have impaired consciousness that can last for quite some time before it comes back. But then they have these little things called automatisms, where they pick at their, maybe you see someone that's just focusing on lip smacking or picking at their clothes, and then when it's all over, they may have amnesia, which is common to this particular seizure. So there's a lot of different things to kind of look at. Also, you may even have something called an absent seizure, which is one where people have level of consciousness is impaired and they're just staring off into space. Febrile seizures, like I said before, is another one. Whoops. Where did I go? Okay. So just to let you know, there's a summary of all of them. Simple partial, complex partial, absent seizure, tonic-clonic. And then at the very bottom, there's this little thing called status seizures. And status seizures mean you have a continuous seizure activity for a very short period, or it could go on for a longer period of time. When people tend to, especially with children, when they go home from the hospital, just in case this were to happen, they are given rectal Valium to take home with them. And if the seizure goes past 5 minutes, typically is when they say, okay, if they're in status, if it goes past 5 minutes, call the medics and give this rectal Valium. Because your rectal mucosa is very absorbent and there's a lot of blood flow down there, and it will take that and distribute it into the body quickly so that you can get seizure relief. Because if you think about it, if you are in status and you're at home, you don't have an IV. So the rectal mucosa is your best bet. Now, I will say of these people, any of these seizure disorders, people have a problem having constant seizures and are admitted to the hospital. As a nurse, you're going to see them usually get a saline lock-in so that you always have like a vascular access, because that would be very necessary. Okay, so if a person has a seizure disorder, you're going to have a healthcare team. You got the nurse, you got the physician and the family, of course, and the patient. And with children, if they have a disorder, you're going to also have to alert the other adults in their life that may be taking care of them when you're not around, the parent. Like the teacher, the school nurse, your Bible school teacher, you name it. And usually these children know that I've had kids before that have come to, for instance, Vacation Bible School, where I've been like a nurse, and they have a little backpack, and in their backpack they have their rectal volume. Or the parents make sure that the nurse on duty has it, because if their seizure goes past 5 minutes, to give that and call the squad. Most seizures are self-limiting and require no medical intervention. A seizure will happen. It'll happen for maybe a minute or so, and it's over with, and the patient just needs to sleep. As far as like a family member, if you have a person with seizures, you would keep track of those seizures. If you're only having one every now and then, of course you're going to let your neurologist know, but because maybe medication that you're on to control them needs to be adjusted. But you're not going to need medical intervention just for a basic seizure. You're going to be fine if it's a known thing. If I have a seizure and I do not know why that seizure occurred, I'm not a known seizure patient, then I would want medical intervention to figure out what the cause was that caused me to have the seizure. And so a lot of tests are going to be done. CBC, you're going to do chemistry, urine culture, lumbar puncture possibly, to take cerebral spinal fluid and look at that, because that can tell you if there's anything going on in the spinal fluid or in the brain. Drug levels if you think the person's on drugs, or drug levels if it's a known person that's on an anticonvulsive agent, to make sure that that anticonvulsive agent is within the right levels. If you have a child, it's very possible children, well, it's not possible that they grow, children grow. So a dose that you have them on, like one time, 6 months later, they could have grown so much that they need more of that drug. You would do an EEG, a CT scan, an MRI, an angiography, or lead levels even. And lead, I was thinking that was on the downward spiral. It was lead poisoning because of all of our new environmental standards and all of our new paint standards. But not putting lead in things. But I have a friend that teaches for the Cleveland School District, and she told me that they're having a rise of lead. I guess in a lot of older homes that the walls have been painted over numerous times, little fingers can chip away at things and get down to the layer where the lead paint level was and chew on that. So that is something to keep in mind as well. I had said before, talking about that there are times if the seizure was to last, like I said, more than 5 minutes with children, they say call the squad, but with the hopes that it's going to stop. But a continuous seizure that lasts more than 30 minutes, or a series of seizures that will not stop, there's one right after another, they usually define that as status. And it needs intermediate intervention, because if you keep having seizures, that's lack of oxygen to your brain. And that means your body's using up its glucose stores, and you need glucose in your brain as well. So you really need to protect the body and get some intermediate interventions. Now, there is another wonderful chart in your book that you will find that's like management of this status type of seizure. That would be a good chart to look at. The number one thing, if someone's having a seizure for this long, if you have just a typical seizure and it lasts for a minute, the person gets a little blue during it, but after a minute they're kind of more arousable and you can reposition them and the airway is not a priority anymore. But if something goes on for this long, the airway starts to become a priority, that you're assessing that and maintaining the airway. And you might have to do that jaw thrust maneuver like I talked about if the airway is starting to get blocked. When a patient is having a seizure, as a nurse, when a seizure patient comes in, I know that by their bedside I need to have suction. I know that I need to have oxygen with an ambu bag that I can give blow-by oxygen if it's needed so that the person doesn't become as hypoxic. And I know that in some places they pad rails of the bed, and in some places they do not. They see that as something where you can't watch the patient as well. So it's going to depend on where you are with the padding of the rails. But you should have oxygen and you should have suction available. Years ago, they used to, when I started nursing school, they would pad tongue blades, and you would stick a tongue blade in the mouth because you had to hold the tongue down so the person would not choke on their tongue. But you're not going to swallow your tongue. It's firmly attached there. You got things attaching your tongue there. You're not going to lose it. The only thing a tongue could do is just roll back and block your airway. But that jaw thrust is all you need to do in order to open that. You can give during this time period, if they already have an IV that's going, you would administer fluids, and usually they give dextrose because I know you're using glucose stores during this time. You have an IV, you don't need that rectal Valium, you can give everything IV, and they usually repeat doses like every 10 minutes if the seizure starts to keep on going. So there's some things there for you to look into. The febrile seizure, just a few more notes on that, that this is the kind of seizure, they're usually not treated with medication like all the others. You just educate the family on if this child starts to look sick and their temperature starts to go up, to administer antipyretics like ibuprofen or Tylenol, but never aspirin because of the risk of Reye's syndrome in children, and protect them from injury. And like I said, they send them home with some tools there to be able to administer if it keeps going on. Seizures in general, place nothing in a person's mouth during a seizure, or you're going to have a choking seizure patient. If the person starts to build up so much secretions that they cannot, like their airways becoming compromised because of it, you can kind of help position them lightly on their side to help with that. Watch for oxygenation. If they start to look like their color is off and they're becoming cyanotic, you can give blow-by oxygen. Padding rails is one way to protect people from harm. Padding rails before the seizure happens is usually what you would do if it's a known seizure person. People with frequent seizures might even have helmets. I took care of a child once that was having 100 seizures a day. That was as many as we could count. And they were like neurologically their level of consciousness, they could not even stand upright. They were wobbly. Their brain was under such assault. We had to put a helmet on them to protect themselves for when they tried to stand up in their crib, that they wouldn't fall over and hit their head and hurt their head. That particular child, they had to go in and cut the corpus callosum. And they found by cutting the corpus callosum, it lowered the amount of seizure activity that the child was having. But that is like that's a kind of like a last resort kind of thing. Medical alert bracelet. If someone has a seizure disorder, having a medical alert bracelet on would be very, very helpful so that people could see that and know that what's occurring is like a known condition. That happened to me once at an Indians game. Somebody went down and they had a bracelet on, and I could see that they were a known seizure patient. So it was kind of like something that I could add to the paramedics and let them know when they came. Administer IV medicines cautiously. When you learn to do IV push and IV meds, you know that a medication is going into the bloodstream and it's going to act very quickly. It's going to act faster than a PO drug would. And so you need to make sure that the drug you're given is compatible with the fluids that are infusing, and that you know how fast that drug is to be administered or pushed so that it does not cause respiratory depression or another problem. Teaching about the meds, medication teaching is very important for ongoing management. And knowing that if it is a child, to emphasize to parents, treat that child like any other child. They just have a seizure disorder. We can learn to live with that. We don't want to stunt their developmental growth because of this. There are support groups out there, and encourage people to acknowledge what they're afraid of or what's going on, so that people can start to kind of be able to express what's going on and kind of feel better, like they're being heard. That's the big thing, is to be heard. The focus is always on safety, maintaining an airway, getting the medications that are ordered, providing emotional support not just to the patient but to the family, and to try to help with that long-term management. just to know there are a few other things here that you will find in your book, because not everything can be so easy. Oh, and also to let you know, one of the best resources for finding out about seizures or to watch seizures and see the difference of them is to go into YouTube, because everyone in the world is taping their seizures and putting it on YouTube. But that's a good thing for us as nurses, because it gives us a chance to see the different types of seizures. And the reason people are doing this taping of seizures is a lot of people, when they go to the doctor and they say, I've had this and this happen, they may look fine. No seizure is going to happen while you're sitting in the doctor's office. And you can have all this testing done and nothing shows up with anything. But if somebody tapes your seizure and you can then show it to the neurologist, they're able to say, oh, this looks like it's a possible this occurring, and you can help get a better treatment plan in place. Just so you know here, intractable seizures, you may see that. And that's about 25 to 30% of children with seizures have this. It's a seizure that continues to occur even when you have good management. No matter what you do or what kind of medications you use, they keep having seizures. So a lot of times you will see people try other methods, because what do you have to lose? The meds aren't helping. What can I do? So the ketogenic diet is something that several years ago came out, and it's kind of like an Atkins diet is the way I would describe it. It is one that's high fat, low carbs, and kind of protein, kind of that. The diet involves a high intake of fat. When I say high fat, up to 80% of your daily calories are with fat. They need at least 1 gram per kilo for protein, and the carbs are kept at a minimal. And when a child is on this, they usually show ketones high in their urine. So if you think about this, some families have felt like this has been helpful to them. But there's things you got to watch for. Because ketone levels are high, they have to be monitored pretty frequently by the family. And there are some complications with this diet, like constipation, or the kids having high lipids, and kidney stones. So there are things that can come with this. It can help people to control their seizures, but it can also cause some of these other problems that people need to be aware of when they're doing this. When you're seizure-free for 2 years, if there's a trial for an anti-epileptic medication withdrawal is often attempted. If you've been seizure-free for 2 years, they'll taper off all your meds and try to see if you remain seizure-free. Because we don't want to put people on meds and keep them on there for their whole life, because they may not need it. Now, with seizures, there's a lot of other things like nursing diagnosis for you to think about. And there's just a few here about the airway, the breathing, the risk for trauma, and the low self-esteem. If I'm someone that's always having seizures and it's limiting different things that I want to do, that could be a problem. Or ineffective therapeutic regimen. Maybe people are having trouble following this. What I would also say, if I were studying for a test myself, when I look at the reading, I would pay very close attention to anything in boxes, because teachers like things like safety alerts and charts and things of that nature. So that concludes seizures. I hope you have found this helpful, and I will see you around. I'll be making more.